Good afternoon, everyone, and thank you for joining us. As Alicia said, my name is Penny Rutledge, and I'm the Director of the Medicaid Care Management and Customer Service Bureau that is in the Michigan Department of Health and Human Services, or MDHHS. My area oversees the contract with the Medicaid health plans. I did notice a question in the chat that is asking if we're going to provide some clarity on the new requirements. That is certainly my intent for my part of this presentation. I am kicking us off to provide some context setting and to share with you an overview of our goals for the mental health framework and how that feeds into the information that's going to be shared by our partners, Milliman. Oh, bear with me as I advance slides here. Okay. I believe I'm on the context setting slide, so if another presenter, if that's not correct, please let me know. So a few years ago, MDHHS launched My Healthy Life, an initiative to strengthen Medicaid coverage through public input and reprocure our Medicaid health plans. Through this process, we collected feedback from nearly 10,000 partners, including health plans, healthcare providers, Medicaid beneficiaries, their families, and community-based organizations, in an effort to design a more equitable, coordinated, and person-centered system of care. Some of you may have responded to our survey. The mental health framework was born out of this effort, with an initial goal of creating a more person-centered approach to serving Michiganders with mental health needs. Now I'll discuss the problems we want to address and the goals and policy changes we want to accomplish before I turn it over to Milliman to share the draft provider rates. We encourage you to provide feedback on the assumptions underlying this rate development, since these rates are intended to provide a reference point to assist providers and Medicaid health plans in contract negotiations. So one common area of feedback received from stakeholders through our survey process is the challenges that are experienced navigating two separate systems for mental health care. One system administered by the Medicaid health plans, or MHPs, and another system administered by prepaid inpatient health plans, or PIHPs. This bifurcated structure has led to several key issues, including gaps in care coordination. Enrollees and their families report getting lost in handoffs across the two systems, and challenges accessing care. Confusion over payer responsibilities, meaning that it's not always clear to health plans, providers, or enrollees which payer, the Medicaid health plan or the PIHP, is accountable for an enrollee's care. And misaligned financial incentives tied to the fact that no one plan is accountable for an enrollee's mental health care across preventive, urgent, and ongoing care. And these were the problems that were identified through the survey that we administered that I mentioned. So as a result of that, the mental health framework was born, and in the mental health framework is our approach to providing more centered mental health care to Medicaid managed care enrollees and addressing the problems that I just described. In response to these problems, our goals with the mental health framework include improving care coordination across systems so that enrollees with mental health needs have a more coordinated experience across the entire range or continuum of mental health services and systems. Clarifying Medicaid health plan and PIHP role and responsibilities to ensure payers, providers, and enrollees know who is responsible for coverage for each enrollee, and aligning financial incentives across the two systems and improving access to mental health care so that enrollees are able to get care when they need it, where they need it. To guide our work developing and implementing the mental health framework, MDHHS has adopted 5 key principles. Minimizing service interruptions for all enrollees, especially for those most at risk for harm from disruptions in care. Maximizing standardization as appropriate across MDHHS programs and systems for all enrollee populations to reduce complexity and confusion. Preserving continuity of care and provider-enrollee relationships as feasible. Ensuring that Medicaid health plans and PIHPs are held accountable for enrollees' mental health care. And being transparent. We want to engage all stakeholder groups as we refine and execute the policy changes that comprise the mental health framework. Next, I'll walk through the policy changes you can expect to see as a result of the mental health framework during our upcoming fiscal year 2026 and fiscal year 2027. Before I dive into the key elements of the mental health framework, I want to clarify what the mental health framework is and is not. The left side of this slide restates what will happen under the mental health framework, while the right side emphasizes what the mental health framework is not. Importantly, the mental health framework is not an end to the behavioral health carve-out. Mental health services for enrollees with higher levels of mental health need, along with other services provided by PHPs today, will continue to be carved out of the Medicaid health plan program and provided by PIHPs. Also important to note is that the mental health framework is not a change to who is providing mental health care. Providers currently delivering mental health services to Medicaid enrollees will continue to do so under the mental health framework. MDHHS will also implement continuity of care policies to allow enrollees to continue seeing providers they have a relationship with for an extended period of time, and encouraging Medicaid health plans and PIHPs to contract with new mental health providers in support of improving access to care. Finally, the mental health framework does not alter the coverage or delivery of waiver services or specialty services for enrollees with intellectual and developmental disabilities. All right, let's talk about the policy changes, which is one of the key things that impacts the individuals on this call. To advance our goals for the mental health framework, MDHHS will be implementing 4 key policy changes in the coming months and years. I'll speak to the timeline for implementation on a later slide, but at a high level, the mental health framework will increase Medicaid health plan and PIHP communication and coordination across the 2 delivery systems. It will standardize the process for assessing enrollees' level of mental health need. This is being accomplished through the use of LOCUS for adults and MichiCANS for children. This is the focus of this rate discussion. It will clarify mental health coverage responsibility, tying plan accountability to an enrollee's level of need, where PIHPs will be clearly responsible for the mental health care of enrollees with higher levels of need, and MHPs, or Medicaid health plans, will be clearly responsible for the mental health care of enrollees with lower levels of need. And it will require Medicaid health plans and PIHPs to cover more mental health care services for the enrollees for whom they are responsible. This will mean PIHPs covering the full array of mental health care for enrollees with higher needs, and Medicaid health plans covering more of the continuum of mental health than they do today for enrollees with lower levels of mental health need. All right, so on this slide, I want to focus on the second point and then the orange box in the bottom. So the standardized assessment process is being launched October 1st of 2025, and that's what we're here to talk about today. So the mental health framework is expanding on the current state policy or community mental health service programs and other PHP providers to use state-designated tools to assess enrollees' mental health needs. So the CMHs and PHPs are already using these tools, and we're expanding the usage of these tools to this provider group that we're talking to today, who are primarily contracted with Medicaid health plans. These tools are the Michigan Child and Adolescent Needs and Strengths, or MichiCANS, Screener for Children and Adolescents, and the Level of Care Utilization System, or LOCUS, for adults. Starting now, as we implement this policy, all qualified mental health providers participating in Michigan's Medicaid program who contract with a Medicaid health plan or a PIHP will be required to use these tools as a part of their assessment of patients. These assessments should be completed annually or upon a change in the enrollee's condition, and providers will need to honor assessments completed by other providers as appropriate. MDHHS will share information on how to sign up for free trainings on both the MichiCANS and the LOCUS tools in the coming weeks. Now I'm going to turn things over to Clay Holman from Milliman, and he will talk about the rates that will be paid, or the comparison rates that we're developing to cover the cost of these assessment administrations.
Thanks, Penny. My name is Clay Holman, and I'm a senior consulting actuary with Milliman, and Milliman has been retained by MDHHS to develop the comparison rates for the MichiCANS screener and the LOCUS assessments. Before we jump into the draft comparison rates, I did want to spend a little bit of time expanding on the context that Penny mentioned regarding the comparison rates and really define what we mean by a comparison rate. The purpose of a comparison rate is to capture and document the average expected costs a reasonably efficient Michigan provider might incur while delivering a service or assessment. The state does not anticipate utilizing the comparison rates as a state-directed payment arrangement within managed care or as a fee schedule within fee-for-service. However, the state does anticipate providing the comparison rates as a reference point to assist providers and the MHPs in contract negotiations as these assessments are added to the MHP's service requirements. Additionally, the comparison rates are anticipated to be used to inform unit cost assumptions within the managed care capitation rate development. And one other item I want to note is that the comparison rate development for the MichiCANS screener and the LOCUS assessments are aligned with the state fiscal year 2026 behavioral health comparison rates where applicable. So a majority of the inputs and assumptions are consistent with that report, and some of our providers today may be familiar with that process, and you may see a lot of overlap between that report and the comparison rates that we will present today. The comparison rates were developed following an independent rate model, or IRM, approach. To provide a little bit of background on the IRM approach, it is a ground-up approach. So we look at the independent costs and items required to provide a service. These are based on the expected resources required to provide the service, or specifically these assessments. The IRM approach is a commonly applied method to develop community-based services and behavioral health services, and it is an approved method by CMS standards for developing fee schedules and rates for these services within Medicaid. Benefits of the IRM approach are transparency. We will spend a lot of time talking through the various inputs and assumptions that are used to develop the comparison rates today, which allows for a lot of transparency in understanding how the final rate was arrived at. The IRM approach facilitates rate updates on an ongoing basis as needed based on changes in the underlying inputs and assumptions. And this approach allows for a comparison of actual costs to the anticipated costs used to develop the comparison rate. There are three primary components within the IRM framework as used for the MichiCANS screener and the LOCUS comparison rate. Those three components are the direct service employee salaries and wages, which includes direct service staff time, the time for a clinician to actually spend with a patient providing the service, and that also includes indirect time spent on documentation and report writing and other requirements to provide that service. That time is captured based on that service member, that clinician's wage, and it also incorporates paid time off assumptions and considers the ratio of staff to person served. The second major component is employee-related expenses to capture all of the additional costs beyond wages that an employee incurs, such as payroll-related taxes and fees and other benefit costs. The final component is administration, program support, and overhead to capture costs of providing the services, such as facility costs and other administration and operating expenses required by providers. And then we do want to note, if you're familiar with the behavioral health comparison rate report, or you've seen this approach used in other areas, another common component of the IRM framework is including transportation expenses. However, for the MichiCANS screener and the LOCUS comparison rates, we do not anticipate transportation being required for this service, as we anticipate is primarily provided within an office setting. And here we've provided a little bit more detail surrounding the individual elements and assumptions and inputs that are captured through the independent rate model approach. I'm not going to cover each of these in detail, as we are going to spend time walking through the specific assumptions used for these services. And now we'll move into walking through the draft comparison rates and the specific assumptions used to develop the draft comparison rates. So on this slide, we are presenting the draft comparison rates. I want to note a few things. The comparison rates have been developed per encounter or per assessment performed. They are not based on a specific time. It is based on per assessment. And so to walk through the various comparison rates here, for both the LOCUS and the MichiCANS screener assessments, we have developed comparison rates for four primary specialty or provider types. That is the specialty physician, such as a psychiatrist, a clinical psychologist, such as a licensed, limited licensed, or the other kind of various licensure statuses as you might expect to find for a psychologist, a bachelor's level staff member, or a master's level staff member with the various licensure requirements listed on the slide. The comparison rates for each of these provider types for the LOCUS and the MichiCANS screener is $109.89 for a specialty physician, and again, that is per assessment, $35.58 for a clinical psychologist, $22.77 for a bachelor's level clinician, and $27.69 for a master's level clinician. So that does provide the high-level overview of the comparison rates. We are going to spend more time walking through how we arrived at these and the individual inputs and assumptions and the modeling involved to develop these comparison rates. But before moving into that, I do want to mention a few things listed in the notes. You'll notice the modifiers listed with each provider, and those are modifiers that would typically be billed on the claim, indicating which provider type the LOCUS or MichiCANS screener was administered by. We are currently reflecting these modifiers consistent with the state fiscal year 2025 behavioral health code charts and guidance published by MDHHS. But we do want to note that final billing guidance, including CPT codes and other requirements for billing these services, are still under discussion by MDHHS and will be published once finalized. I do also want to note that while we have listed the main clinician provider type here, there is also time included in the rate development to account for supervisor time specifically for the bachelor's level and the master's level clinicians. And next, I'm going to walk through an example comparison rate development model so that you can see and we can walk through how the inputs are used to arrive at these values. I do want to mention we are going to focus on a single example, one of these comparison rates, but we have provided all of the comparison rate models as an appendix to these materials, which are available to download within the Adobe Connect software and will also be posted publicly for further review. So to move into the example rate model, we have selected the MichiCANS screener to walk through here in detail. And specifically, this is the bachelor's level. A few notes as we start to walk through the MichiCANS screener rate development model. Along the left side of the exhibit, you'll see a reference column. And that reference column can be used to identify each row of the comparison rate model. And you'll also see on the notes on the right-hand side, we've included formulas to provide a sense and really illustrate how many of these values are calculated. The development of the comparison rate starts with how much time does a clinician spend working on performing an assessment, both direct time spent face-to-face with a client or a patient, as well as the indirect time needed to finalize the service, reporting requirements, and any other requirements required for administering the MichiCANS screener. We have highlighted our key assumptions here, 22 minutes of direct time and 3 minutes of indirect time. And I wanted to note that these assumptions were developed based on input from an internal work group of MichiCANS screener and LOCUS experts within MD-HHS. Adding that direct and indirect time arrives at a total of 25 minutes of clinician time per assessment, per MichiCANS screener assessment. And from there, if we continue working down the clinician column, we add an adjustment factor to account for PTO, training, and conference time. For a bachelor's level clinician, that adjustment factor is estimated at 15.6%. I will cover the individual assumptions and inputs used within that adjustment in more detail on a later slide. After we add in that adjustment factor, we arrive at a total of 29 minutes per unit per assessment of clinician time. And combining that with the hourly wage assumption for a clinician of a bachelor's level, we arrive at our total expense per unit for direct and indirect time and PTO and training time of $12.33 for the clinician. And then moving down to row L and M, this is where we capture the employee-related expenses to capture the payroll taxes and benefits and other items associated with that wage expense. And that adds an additional $3.74. And that ERE percentage, similar to the PTO and training adjustment factor, I will cover in more detail in a later slide. So we've walked through the clinician rate development. The supervisor rate development is similar. However, instead of forming assumptions around the average minutes of direct and indirect time for a supervisor, the assumption is based on the supervisor's span of control to assume to review how many employees are assumed to be managed by a single supervisor. For the MichiCANS screener and the LOCUS assessments, based on discussion with the internal work group, we have applied a span of control assumption of 10. And based on that assumption, we add 2.5 minutes of supervisor time per direct care worker into the rate development for the MichiCANS screener. That time is converted to a cost based on the PTO, training, and conference time adjustment factor, the hourly wage assumption, and the ERE percentage as we walked through for the clinician. Adding those components up for the clinician and the supervisor arrives at a total cost of $13.89 for wages, $4.16 for the employee-related expenses, and then to capture that third component of administration and program support, we've applied an assumption of 20.7% to incorporate those factors. Again, that accounts for the facility expense and general operating expenses of providers. And adding those three components together arrives at that final rate per encounter of $22.77. So I know I walked through that rather quickly, but we do want to save time to walk through the individual inputs and assumptions. And again, we did want to note again that we did walk through the detailed rate model for the MichiCANS screener for the bachelor's level staff, but all of the 8 comparison rate models have been provided as an appendix of this presentation. To spend a little bit more time discussing the assumptions for the MichiCANS screener and LOCUS, we wanted to start by speaking through some of the general assumptions around time and also the administrative overhead related to these services. To start with the time assumptions, I noted on the prior slide the MichiCANS screener. We applied assumptions of 22 minutes of direct time and 3 minutes of indirect time for the MichiCANS screener. For the LOCUS assessment, we applied an assumption of 0 minutes of direct time and 25 minutes of indirect time. And to provide a little bit more context on that, based on our discussions with the internal work group, we understand that the LOCUS assessment is typically completed following a span of 2 to 3, generally 2 to 3 face-to-face encounters and therapy, evaluation, counseling, or other sessions that a clinician might spend working with a patient. Following those 2 to 3 face-to-face encounters is when the LOCUS assessment we anticipate would be completed. In those 2 to 3 encounters of, again, working through the therapy evaluation, the counseling, we anticipate would be billed and reimbursed separate from the completion of the LOCUS assessment itself. And so for that reason, we have not applied an assumption for the direct minutes, or the assumption is 0 direct minutes. But we understand that still completing that LOCUS assessment following the face-to-face time with the patient takes approximately 25 minutes, and that is how we arrived at that assumption. The supervisor's span of control, as mentioned, is assumed to be 10 for both the MichiCANS screener and LOCUS. And this assumption is primarily based on both discussion with the internal work group as well as consistency with the state fiscal year 2026 behavioral health comparison rate report. And finally, the administrative overhead assumption of 20.7% was also based on the assessment and testing service category within the state fiscal year 2026 behavioral health comparison rate report. Now, as I'm walking through these time assumptions and some of the other assumptions, I do want to note that when we are referencing the MichiCANS screener, the comparison rate that we've developed for the MichiCANS screener is intended to be just the brief screening that would happen before a full CANS assessment. And so I wanted to mention that to ensure there's not any confusion around what do we mean by the MichiCANS screener. It is a brief screen that would take place prior to a patient performing that full MichiCANS assessment. To move into our next category of assumptions, wanted to spend a little bit more time walking through the PTO, training, and conference adjustment factor that I mentioned as part of the example rate model a few slides prior. These adjustment factors are intended to capture all time that a staff member is paid but not able to perform assessments throughout the course of a year. To develop these factors, we start by looking at the total working hours per year. Total hours an individual is assumed to be paid, assuming full-time staff members for a typical year. And then we add in the individual components that might take time away from actual direct work time for that individual. So starting with column B, we incorporate time spent for paid holidays and PTO, and this build up, all of these values are hours. And so we have reflected 240 hours of both holiday and PTO time per year. That is approximately 5 to 6 weeks, depending on the provider level, as you can see there, but approximately 5 to 6 weeks per year of holiday and PTO time. Next, we add in ongoing training, conference time, time needed to keep a license, continuing education requirements, and that sort of thing. For that assumption, we've included 40 hours per year. Adding those two items together, we get approximately 280 hours per year for most of our provider groupings and 240 hours per year for the bachelor's level provider grouping of non-productive time per year for a standard employee that's kind of an established employee that has been working for 2+ years. But we also understand that turnover happens, and especially when new hires join an organization, there's training time, there's inefficient time required to get a provider up to speed and working a full caseload. And so columns E, F, and G account for this by assuming a number of hours, specifically 40 hours for most provider groupings or 80 hours for the bachelor's level provider grouping, of that general training and inefficient time for new hires. We also consider the turnover percentage of approximately 50% for these provider groupings. And combining those two items adds an additional 20 to 40 hours of that new hire training time per year, as you can see there in column G. Combining the non-productive time per year for established employees and new employees arrives at our total non-productive time for the year of approximately 300 hours, or 280 for the bachelor's level, as seen in column H. And we use that to look at how much annual productive time is left over per staff member. And finally, we turn that into the adjustment factor of 16.9%, or 15.6%, as noted and walked through on the example rate model a few slides prior. And again, I mentioned this as walking through some of the inputs and assumptions, but the PTO and training assumptions were developed based on a review of licensure requirements and survey responses collected through the state fiscal year 2026 Behavioral Health Comparison Rate Report development. Penny mentioned this earlier in the presentation, but we do also want to mention that training for the MichiCANS screener and the LOCUS assessments will be provided directly by MDHHS. Next, I want to provide a little bit more detail on the wage analysis and the specific hourly wages used within the comparison rate development. On this slide, we've included the hourly wage assumptions for our 4 provider groupings. I will note you see 5 rows there on the screen. So when we are developing the hourly wage assumptions, one of the primary data sources that we use to develop these assumptions is from the Bureau of Labor Statistics and information that they report on wages. That information is available at various percentiles, and we generally focus on the median wage level as published by BLS. However, there is one comparison rate type that utilizes a 75th percentile wage assumption for the master's level staff member, and that is supervisor time for a master's level clinician. So again, just to walk through that again, for the master's level comparison rate, if the clinician is at a master's level, the supervisor time is captured at a wage at the 75th percentile, while the clinician is at the median. To provide a little bit more background on the development of these wages, it is consistent with the state fiscal year 2026 behavioral health comparison rate analysis. Those wage assumptions were developed following a process that was based on survey data, and a process was applied to that survey data to smooth responses and remove outliers, and also ensure that the survey responses were credible and supplemented with that BLS wage information. We also provided trend to ensure that the wages reflect levels anticipated for the state fiscal year 2026 time period. I know I covered that at a very high level, but the 2026 Behavioral Health Comparison Rate Report is available at the link included within the slide, and more information on the wage development is available within that report. The final component to walk through is the employee-related expenses and the buildup of those percentages included in the comparison rate model. To walk through this, again, you will see the 4 major provider groupings. And we start with the wage, which again, for most of our provider groupings and most of the rows on this exhibit is the median wage level, except for that final row where noted, which reflects the 75th percentile. To develop the employee-related expense percentages, we start with the annual employee salary assumed for each provider level. And then we add in the costs associated with each of the payroll taxes and benefits required or provided for the staff members. Columns C, D, and E are all various payroll-related taxes. FICA and FUTA being the federal income and federal unemployment taxes. And those assumptions are based directly on IRS guidance and input applicable to the income and unemployment taxes. Similarly, column E is state unemployment tax and is developed based on information related to the Michigan State Unemployment Tax Program. Finally, column F is the workers' compensation. And this assumption is consistent, again, with the state fiscal year 2026 Behavioral Health Comparison Rate Report, which assumed approximately 1.18% assumption for workers' compensation, and that 1.18% assumption is applied to the annual employee salary to arrive at the values that you see there. Column G captures the health insurance costs for state fiscal year 2026. Behavioral health comparison rates. The assumed health insurance cost is roughly $8,000 per employee per year. And that's based on benchmarks published by the Bureau of Labor Statistics and trended similar to wages to ensure that we're capturing anticipated health insurance costs during the state fiscal year 2026 time period. And finally, column H includes the retirement expense and retirement benefits. And that assumption, again, consistent with the 2026 behavioral health comparison rates, applied an assumption of 4.7% of annual salary to develop that assumption. And so combining all of the items from C through H there arrives at the total employee-related expenses anticipated per staff member in column I, ranging from roughly $16,000 for a bachelor's level staff per year to roughly $44,000 for a specialty physician per year. And finally, we convert that annual cost to a percentage in column J. And that percentage, again, ranges from 13% for a specialty physician to roughly 30% for bachelor's level staff. And that percentage represents what is the total ERE cost per employee relative to an employee's salary level. And that percentage is used directly within the comparison rate model in the IRM approach as presented on a prior slide. So we've spent some time walking through the various inputs and assumptions today. Do want to mention that these specific assumptions are the areas that we are looking for feedback on. To the extent you have feedback, these draft inputs and assumptions are subject to further revision based on the feedback we are collecting today. And for that, to close this out, I can hand it back to Alicia and Amanda to walk through the process of collecting feedback and next steps.